Thank you for joining us for Racial Disparities in Clinical Communication, hosted by the Society for Health Psychology Women's Health Interest Group and co-sponsored by the Society of Clinical Psychology, APA Division 12. I am Barbara Keaton, Administrative Officer for the Society. Before we begin, we have a few items to share. This event is being recorded. Anyone who speaks during it, for example, to ask a question, is agreeing to be recorded and is granting permission for the recording to be posted to our website. If you are not already muted, please do so now. This webinar is eligible for 1 continuing education credit under the Society of Clinical Psychology Division 12 sponsorship. CE evaluation information will be sent via email shortly after the webinar. All participants are invited to submit feedback by the evaluation, even those not seeking credit. We will leave the evaluation open until 5 p.m. Eastern on June 25th, 2021. CE certificates will be sent via email within 5 to 10 business days after the evaluation period closes. Questions for this presentation will be taken at the end. You may either submit them via the chat feature or you can use raise your hand and you will be called upon to ask your question. And now I will turn the screen over to Dr. Ellen Polishuk, Chair of the Women's Health Interest Group, to begin the presentation.
Thank you so much, Barbara, and thank you so much, everybody, for joining us today for the second of 2 webinars in our series entitled Striving for Health Equity for Black Women, 2 Psychologists Share Their Work. If everybody could please mute, that would be great. Thank you to the Women's Health Interest Group Steering Committee, Dr. Annika Johnson-Campbell, Dr. Jessica Clifton, Dr. Mona Elgohill, Dr. Christina Hood, and Dr. Marcy Lobel for your hard work in putting this exciting series together. I'm grateful to the Society of Health Psychology, including Dr. Helen Coons and Barbara Keaton, for making this opportunity available to the members of Division 38. I also want to thank Division 12 for making continuing education credit available to all participants. Before introducing Dr. Bell, I want to take a minute to invite you to consider joining the Society of Health Psychology Women's Health Interest Group. The Women's Health Interest Group provides a welcoming, collaborative space to connect with others who have shared interests to address women's health issues in psychology and society. Membership is free to anyone who is a member of Division 38. We hope you will sign up to participate on the listserv and receive announcements about events that are taking place. Please just email Barbara Keaton or me if you're interested in joining. I'll put our contact information in the chat. Now I'm pleased to turn our attention to our speaker today. I'm proud to introduce my colleague, Dr. Keisha Bell. I've had the privilege of working with Dr. Bell since she first came to the University of Rochester Medical Center as a fellow, and she did such a great job. We invited her to stay on as faculty. Dr. Bell is assistant professor in the departments of OBGYN and psychiatry at the University of Rochester Medical Center. She is a clinical psychologist, communication educator, and coach in the Department of OBGYN. Her work serves on teaching patient and family-centered communication skills. Dr. Bell serves as co-officer of diversity and inclusion in the Department of Obstetrics and Gynecology. In her role as an embedded psychologist at an outpatient OBGYN practice, Dr. Bell provides consultation, education, and brief therapeutic support to adult women at all stages of life. You're in for a treat. Now, Dr. Bell, I know, has left a few minutes at the end for us to have some conversation and discussion. So please put any questions you'd like her to address in the chat, and I'll go through those questions at the end. And now I'll turn it over to you, Dr. Bell. Thanks very much.
Thank you so much. Just wanting to make sure that everyone can hear me all right. I do have my volume turned up. I am such a soft-spoken person, so let me know if there's any difficulties hearing me. Thank you. I would like to acknowledge the Women's Health Interest Group, Division 12 and Division 38 for allowing me to share a little bit of what I do with you all today. So I'm very excited to be here and feel that it's a privilege. So thank you so much. Today we'll be talking about racial disparities in clinical communication. Disclosures, I have no financial disclosures or conflicts of interest with the presented material. So what are our learning objectives for today? By the end of today's session, you'll be able to describe some of the historical factors that led to my career in women's health and some of the contemporary factors that inspire my work and my professional interest. You will be able to identify racial disparities in maternal health and clinical communication and describe 3 ways in which clinicians differ in their communication with Black patients as compared to white patients. You will be able to describe the ways in which I apply my knowledge of Black maternal health disparity and communication disparities to my professional work. And by the end, you'll be able to walk away with some strategies for improving patient clinician communication with Black patients. So the year was 1988. Can you tell by the ruffles and the lace? I am 5 years old in this picture. It was Easter Sunday. I'm in the center. Coming down or going up, I'm not sure, on a sugar rush from all the Easter egg candy. I'm likely saying something incoherent and probably only funny to me. My brother is in the back. I'm sorry, I jumped ahead here. My brother is in the back behind me in the grayish blue suit. He's looking down, probably reminiscing on the days when he was the only child and center of attention. My mother is to the left of us with a sly, incriminating grin. Perhaps she's the one who gave me all that candy. Perhaps she's hoping I'll go down for a good nap once we get into the car. Onlookers say something like, "Oh, how precious," as they wait for someone to interpret my sucrose-induced calories. Five years later, my mother died of cancer. The year was 1992. It was May when she learned of her lung cancer, and before the start of my 4th grade year, she had passed away. A late-stage diagnosis. A smoker, an underinsured woman working in the school cafeteria, an extrovert who never met a stranger except at the doctor's office, which she rarely visited. I'm comforted by the stories of her somehow being able to make meaningful connections with the nursing staff during her cancer treatment. Turns out, in fact, she never met a stranger. I was reared by my grandmother, who died of cancer 6 years after my mother. The year was 1998. After winning a battle with breast cancer several years earlier, she lost the fight to ovarian cancer. Nonetheless, my grandmother was a survivor, a woman with a 4th grade education whose mother died when she was 4. My grandmother survived the Jim Crow South, KKK domestic terrorism, and desegregation. Yet, she only went to the doctor when all else failed. I vividly remember her taking a spoonful of mustard once when her blood pressures were too high. And per a recent Google search, mustard may have some blood pressure benefits. How did Granny know this wisdom? Clearly, women's health and illness and death were an early part of my life, and I naturally took interest in health and well-being. I questioned things like, why don't people go to the doctor more? Why don't people change their behavior? Which led to more evolved sociocultural questions like, why do all the Black people live on a certain side of town? Why are the Black people sicker than everyone else? It only made sense that I'd eventually pursue a degree in clinical psychology with an emphasis in health psychology and have a strong affinity towards women's health. You may be wondering at this point, why in the world would a photo album contain both personal photos and stark diagnostic imaging? Don't they belong in separate albums? What I've learned thus far is that this is the common conflict in medicine, holding both humanity and the biomedical. The challenges of seeing them both together. That patients have lives and dreams and aspirations, just like my mother and my grandmother and all of us. A graduate professor once gave me the feedback, Keisha, you tend to take 2 ideas that seem completely unrelated and find commonality in them. Perhaps that's just who I am as a person. And as an early career psychologist, I view my current professional role as helping others see those connections that often go unnoticed, see patients as living narratives, and to ask those why questions that push quality of care forward. I'll share some of the ways in which I do this in my professional work a little later in this talk, but for now, let's fast forward to the present day and review some of the contemporary inspirations for the work that I do. The year is 2021. and racial and ethnic disparities in reproductive healthcare are well documented. Compared to white women, Black women are more likely to experience complications throughout their pregnancy and in the postpartum period. They're 3 to 4 times more likely to have a pregnancy-related death than white women, and are more likely to have a preventable maternal death compared to white women. Postpartum depression is the most common complication of childbirth, and there's data to suggest that new Black mothers may experience perinatal depression and anxiety at twice the rate of white women. Yet, Black women are less likely to receive treatment, and when they do, they're less likely to follow up. This is significant because postpartum depression is a treatable condition, and left untreated, postpartum depression has been linked to poor maternal bonding, premature birth, behavioral and developmental delays in the child, which perpetuate disparities, given that these adverse outcomes can be prevented or avoided or reduced. Disparities are also seen in preterm birth deliveries, which is more common among Black women than white women, and infant mortality rates, which are twice as high in Black women versus white women. Data shows that maternal health disparities persist even when variables such as risky behavior, obesity, educational attainment, socioeconomic status are all controlled for. In particular, socioeconomic factors do not appear protective for Black women. For example, one study revealed that Black women with doctorates and professional degrees have a higher infant mortality rate than white women who never finished high school. This disparity for infant mortality exists at all educational levels, and it's the greatest for those with a master's degree or higher. Pictured above is Kira Johnson. Kira Johnson spoke 5 languages. She worked as a pilot and enjoyed to travel and traveled the world. She was a wife and mother of 1 son, pictured with her there, and no real major health conditions. When Kira became pregnant with her 2nd child in 2016, she underwent a cesarean surgery. Her health began to decline shortly after. Over the course of several hours, her husband and her family noticed this decline. They noticed blood in her catheter and that Kira began to shiver and was pale. They tried to get medical staff to check on her, but 10 hours went by without having her symptoms addressed. She eventually died of complications related to postpartum hemorrhage. The Kira Johnson Act was introduced to the House of Representatives in February 2021 and is awaiting passage. The bill is intended to provide funding to end preventable maternal mortality and severe maternal morbidity in the United States, and to hopefully close disparities in maternal health outcomes. Kira's story, and like others like it, challenged this mother-blaming narrative, or the bootstraps narrative, and begs the question, what factors are at play here? Is there something about the way in which a pregnant woman interacts with the healthcare system that may help us understand these outcomes? So let's talk a little bit about some of the contributing factors for maternal health outcomes. Given that 40% of maternal deaths are preventable, factors such as hospital quality, institutional racism, and provider bias have gained increased attention as contributors to disparities. Numerous studies demonstrate that patients of color, compared to white patients, receive fewer recommended treatments for diseases ranging from cancer, HIV, heart disease, even after controlling for insurance status and access to a regular primary care physician. Newer studies show that Black women receive obstetrical care that is suboptimal and is lower in quality, and in lower quality hospitals than whites. For example, Black serving hospitals have higher rates of maternal complications than other hospitals, even after adjusting for socio-demographic characteristics, clinical factors, and hospital characteristics. These hospitals also perform worse on 12 out of the 15 birth outcomes, including elective deliveries, non-elective cesarean births, and maternal mortality. Standards of care for addressing obstetric emergencies vary in clinical performance and best practices. This means that some women receive appropriate high-quality care while others do not. Scholars contend that the legacy of racism in our country creates an imbalance of inherited resources for whites and persistent disadvantages for Blacks. That from the time of slavery, determinants of Black maternal health, such as education, income, neighborhood characteristics, housing, access to care, safety, and food have been dictated by structural racism, which have led to disparities in health. Moreover, there is a legacy of poor treatment of Black patients by the medical system, including experimentation and exploitation of Black people, going back as far as slavery. Pictured here is John Marion Sims, considered the father of modern gynecology and former president of the American Medical Association. He performed reproductive experimental surgeries on unanesthetized slave women to perfect his surgical technique. Other injustices include surgeons hired to board the Middle Passage to preserve Black cargo, the Tuskegee syphilis experiment, use of cell cultures without consent, such as Henrietta Lacks, and forced sterilization. Some studies show that healthcare providers still hold ideas that Black people have less sensitive nerve endings, thicker skin, stronger bones, which may cause healthcare providers to rate Black patients' pain much lower and result in less appropriate treatment recommendations. The landmark Institute of Medicine's 2003 unequal treatment report, emphasized the potential influence of patient-clinician communication on both mitigating and perpetuating health disparities among racial ethnic groups. Factors that may contribute to health disparity in the clinical relationship include power imbalance, clinician unintended bias, and clinician communication skills. Implicit bias refers to negative attitudes towards and beliefs about a group and its members that are spontaneous and automatically generated. Studies show that healthcare providers hold unconscious negative stereotypes of Black patients as being less educated and less likely to be adherent than white patients. And findings from focus groups suggest culturally insensitive communication as a result of bias. One Black participant recalls, "I've had both positive and negative experiences. I know the negative one was because of race. It was with the previous primary care physician when I discovered I had diabetes. He said, 'I need to write this prescription for these pills, but you'll never take them and you'll come back and tell me you're still eating pig's feet and everything. Then why do I still need to write this prescription?' And the patient was like, 'I don't eat pig's feet.'" Findings from a 2018 systematic review suggest that Black patients tend to have poor observed communication and worse self-reported perceptions of patient-physician communication when their physician is non-Black. Communication for Black patients regularly includes less information sharing, less active participation for the patient, and less patient decision-making involvement. And patients also report lower levels of trust in physicians and lower levels of satisfaction with care. Strong evidence in the social psychology literature shows that implicit racial bias can influence nonverbal and paraverbal behaviors, things like body posture, eye contact, the amount of speech, the speed of speech, the pitch of the speech. Research indicates that white providers who score higher on measures of implicit bias dominate conversations, have shorter visits, display less warmth, have fewer positive nonverbal cues, such as positive affect. And they use more first-person plural pronouns. So we're going to start exercising, right? We're going to start taking our meds, right? Which seems to have a more authoritative tone, And this is more often the case with Black patients than with white patients. Additionally, other studies have found physicians engage in more narrowly biomedically focused conversation, and conversation that is less patient-centered. Research in obstetrics is limited, but there's data to suggest that Black women are more likely than white women to experience poor communication during perinatal health encounters. For example, one study examining mistreatment during pregnancy and childbirth found that Black women were more likely to have experienced mistreatment by a provider compared to white patients, such as being shouted at, the provider ignoring the patient's request, violations of privacy, feeling that they were coerced into some type of a treatment, and having their pain dismissed. Preliminary qualitative data suggests Black women who report feeling mistreated were disinclined to attend subsequent prenatal visits, especially if there was perceived lack of trust, lack of clear communication, closeness, and continuity. Pregnancy involves increased engagement with the health system due to the frequency of the prenatal visits. The implications of poor quality communication is especially relevant to Black women who are at increased risk for adverse maternal health outcomes. It's theorized that substandard communication may contribute to health inequities for Black patients through intermediate outcomes, including low trust, satisfaction, treatment adherence, and attendance, as I mentioned a moment ago. Provider implicit bias can lead to verbal and nonverbal behaviors, so less partnership, talking over the patient, facing the computer, that can lead to poor satisfaction and trust, which may then impact patient behavior. So, for example, patients not attending their appointments. This is important because studies suggest that positive physician affect may moderate trust and may have greater consequences for continuance in treatment for Black patients over white patients. For example, patients' communication with providers correlate with adherence to medical advice. And so patients who have better experiences are also patients who experience better health outcomes, and there's a correlation there. Communication is a constant feedback loop. So for example, patients may perceive physicians as being insensitive to their needs and therefore communicate less with them, ask fewer questions, maybe appear disengaged, which physicians may then interpret as passivity, low intelligence, thus exacerbating the disparity. Having repeated positive communication interactions with Black patients may actually help to reduce implicit racial bias, as it helps the provider to what's called individuate, to see the patient as a person and not a stereotype. Studies indicate that clinicians tend to overestimate their communication skills, even when patients view the communication exchange as inadequate. This suggests that clinicians may be unaware of communication blind spots that could impact the quality of their clinical encounters. Improving provider communication behaviors might be a more practical and attainable approach to improving care outcomes for patients than our strategies aimed to reduce implicit bias per se. Oftentimes, those strategies increase awareness, but don't offer specific communication strategies that can be changed. So how do I incorporate all of this information into my practice? How does my work involve maternal health? And how does it involve communication? I'll tell you a little bit about that. So I try to take all of this information and apply it to different levels, the patient level, the provider level, and the institutional level. The goal is to create a culture of feedback and humility. Researchers recommend that medical education train healthcare providers to think about how variables like race, class, gender, ethnicity are shaped by the interactions of the persons in the room and by the larger structural context in which the interactions take place. One of the ways that I try to blend the two of those is through my role as a communication educator in the Department of OBGYN. I am a part of what's called a coaching academy. There's a communication coaching program at our institution, and it involves teaching communication skills to physicians and other healthcare workers. The communication coaching program was developed by Susan McDaniel, former APA president, in 2011 to enhance physician-faculty skills in patient and family-centered communication, and to improve the patient care experience. Coaches are mostly psychologists or psychology fellows and undergo a 2-year training period to learn research and communication, observational coding, report writing, team dynamics and communication, and feedback delivery. Coaches are embedded in multiple departments across the institution, including family medicine, surgery, pediatrics, ophthalmology, and OB, where I'm housed. In my coaching role, I work primarily with medical residents in the OBGYN department. I conduct real-time observations of their clinic. So I will follow them for at least a 4-hour block. And then I will kind of code my observations, complete a comprehensive report that I give to them, and then we sit down for verbal feedback, and we identify what their strengths are, their goals for improvement, and strategies to improve communication. Communication coaching is a strengths-based approach. It's not an aha, I caught you doing something bad. Actually, physicians have many strengths, and there are areas that are blind spots that feedback is helpful to have them address. So an example of feedback is to perhaps ask about patient preferences, preferences in language, preferences in name. Try to avoid using terms of endearment like, okay, honey, all right, sweetie, my dear, because those can be infantilizing and off-putting to patients. Make sure that you're sharing the decision-making. For example, a provider may refer a patient to mental health, but not ask them if they're ready for a mental health referral or if they even want the referral. And then the patient doesn't keep the appointment, which creates a delay in access to other patients who are ready for the appointment. So it addresses both the individual component and the systems level component. There are some times where you see providers talking really fast, especially when they realize they're running behind. And this can undermine whatever good communication occurred at the beginning of the visit because the patient then feels rushed and unheard, and they're not able to ask clarifying questions which can impact the plan. The biggest source of feedback that I give is about agenda setting and creating partnership with patients. Sometimes the agenda is missed to save time, but it ends up costing time in the end, especially when patients present with multiple complaints and you feel like you have to address all of them. If you set an agenda, you're more likely to have a partnership with the patient where you negotiate which agenda items will be addressed and then create a plan for the remaining agenda items. One of the things I like most about these skills that we teach physicians is that they're really, oftentimes they have multiple benefits. So for example, the skill of asking the patient a question about themselves, just as a person outside of the medical context. This creates therapeutic rapport, it eases anxiety, it provides you with contextual information that you wouldn't get otherwise. For example, the patient took 2 buses to get here, or they're unemployed now, or there's food insecurity. It reduces implicit biases by allowing you to see the patient as an individual and not a stereotype. Turns out you both maybe like a particular show, or there is something about that patient that is a commonality for you as well. And lastly, patients feel seen and heard as it individualizes care. So one question, all of those benefits, that's efficiency. Other iterations of this role include being a part of the larger institutional coaching academy. So that means at times I work with providers outside of OBGYN, which allows for a broader reach of the educational program. Another way is that I teach communication skills by working in small teams with residents. So for example, if a resident is struggling in a particular domain or a couple of domains, they will have a team assembled for them who are experts in that particular domain, and will work one-on-one with the resident to help them improve their skills over time. So I'm often called upon because there's a communication component. So either the resident is struggling with how to solicit feedback, how to set expectations with attendings, how to organize information in a way to combat anxiety. And so I'm able to work with them in a smaller setting to have their skills be improved over time. Lastly, I teach didactics to the residents and fellows in the department and faculty outside of the department at times. And I also am involved in some of the resident educational opportunities. So there are simulations, providing feedback about their communication with the standardized patient. And I have also been involved in helping them to learn patient-centered communication when working with patients who have a substance use disorder. So the next way in which I incorporate all of this knowledge of disparities work is my role as a co-officer of diversity and inclusion. We've submitted several grants to to study communication, coaching, and perinatal women, but as you know, getting funding can be challenging. However, we did receive a Patient Safety Award grant to create a patient advisory board in the Department of OBGYN. And the immediate goal is to partner with Black patients and their families to understand their experience in our hospital setting and to work with them in partnership on patient education materials related to pregnancy-related hypertensive conditions and postpartum hemorrhage, which, as I mentioned earlier, affects Black women at much higher rates. The plan is to compensate these women monetarily for their lived experience expertise. And the long-term goal is to sustain a relationship with the community stakeholders to eventually review policies and practices that are potentially biased or discriminatory in our institution. A few colleagues and I have a paper in review that outlines the communication coaching process and how psychologists are poised for this type of work. And so hopefully that will help to push this information forward as well. Lastly, in the diversity officer role, our institution has partnered with the Department of Health in a birth equity project that has several different kind of balls in the air and measures and metrics. But one of those metrics is to include the patient's experience in the hospital through a survey, asking about how their experience was, how their care was, and asking if they had any experiences of discrimination. And hopefully that data will help us to better understand where we need to target our efforts in our own institution. In my role as a clinician, I listen to patients. I identify where miscommunications are and collaborate with their team. I share recommendations for care with their team, including communication strategies, curbside education about mental health conditions and how to communicate more effectively with the patient are often conversations I have. I do that in a way to try to engender empathy for patients and to help, again, for providers to see patients as people and not just MRN numbers and other metrics. I also promote patient advocacy. So in my visits with patients, I ask them, if they've told me something, do you feel comfortable sharing this with your doctor? Have you considered asking your doctor to clarify these questions? Have you taken a list of some of your concerns to your doctor that maybe can help you better organize your thoughts when you're in the visit? And then lastly, I have a consultation role, like all of us probably do in some capacity. Sometimes people within the department or outside of the department will reach out to me for various projects. And so one project that we have ongoing is a reproductive justice course in the Department of OBGYN. And that involves collaboration with bioethics and OB. And the goal is to increase awareness of structural determinants of maternal health. And we envision this being an interprofessional learning experience. There have been times I've been called on to be involved in patient relations complaints to provide an equity and communication perspective. So for example, maybe a patient felt that there was bias or discrimination, and so looking at where the communication breakdown occurred. And then I also work with providers who may be having issues with their communication with patients or with other team members. We know that team communication impacts patient safety, which is a hospital quality metric. And so if teams are communicating well, hopefully that might reduce some patient safety issues. And I'm also involved in the residency clinical competency committee meetings, and I collaborate with faculty about resident milestones. We share our similarities and dissimilarities of our observations and I provide some strategies for the faculty in delivering feedback to residents. And we track the residents' progression in their communication milestones over time. So what can you do to improve communication with Black patients, which is probably why you're here? I want to give you a few tips in terms of one-on-one interactions with patients and then in overall your clinical setting. Number one is to listen to patients. The one-on-one application of that is pretty obvious. In psychology, we do a really good job asking about patients in terms of their social, family, work context, and we can maybe omit their experiences in the healthcare setting. And so extending those questions to how have they been treated in the healthcare setting? What's their experience like? And understanding the challenges that they face. Asking feedback from patients. So was there something that I could have done differently today that would have made this experience better for you? In terms of systemic level application, thinking about how to incorporate patients' voices into the practice. So maybe there's a focus group that's held before beginning research with Black patients, or maybe you survey Black patients about their experience in the office and implement the quality improvement project. The second way is through individuation. This is seeing the person as an individual rather than a stereotype, learning about their personal history and the context that brought them into the doctor's office. The one-on-one application of this is asking about the patient as a person, as I mentioned a moment ago. One way to do this is to say, I always like to get to know my patients as people. What personal goals do you have? What plans do you have after this visit? Or having potentially a list of questions that you might use across visits that you can ask patients to get to know them as people. The systemic application of this is using person-first language when talking to colleagues about patients, to educate medical colleagues about communication disparities, potentially through staff meetings or brown bags or journal article clubs, to help increase awareness of the issues that Black patients face in the healthcare system. A third way to do this is through partnership building. So this includes reframing the interaction with the patient as one between collaborating equals rather than this higher status person and this lower status person. The one-on-one application of this is that having the mindset that there's two experts in the room, making sure to elicit patient preferences, watching nonverbal communication. So in your role, do you use a computer or an iPad? Or do you use the WOW, the workstation on wheels? And is that creating a barrier between you and the patient? Is there another way to engage the patient if you need to use those materials, like having the patient look on with you, or asking the patient or telling the patient that you are, charting, I'm writing down what you're saying, and this is what I heard you say, so keep them involved. The systemic application is investing in community stakeholder relationships. Who are the trusted and revered community leaders? And how might you partner with them to best serve patients? Maybe you do a panel like we've seen with the COVID vaccine around mistrust, or maybe a workshop with community leaders on certain health behaviors that you see affecting your patients more heavily than maybe some other patients. Consider changing pictures. When the patient walks in and there's not representation in the staff and faculty, and then also not representation in pictures and brochures, it can really feel isolating. So potentially consider changing pictures to have more diversity and inclusion. The same with office materials. Lastly, be aware of medicalization. So for psychologists in integrated care settings, it's easy to adopt a medicalized view of patients for shortcuts in written and verbal communication. So we can unfortunately fall into the habit of viewing patients as a series of data points, diagnostic labels. This patient is a number, fill in the blank on a scale of 1 to 10, and lose sight of the patient as a person. The one-on-one application of this is, again, person-first language. Also, being mindful of documentation that could be priming. So non-compliant, drug abuser, med seeking, these could be bias priming words or phrases that create maybe an unpleasant visit for whoever's meeting with the patient next, as this person might begin to create a narrative in their mind about who this patient is, which then perpetuates feelings of feeling unheard and not being seen, which then perpetuate disparity. Another way to do this in a one-on-one application is to role play with your patients. What might they say to their provider about what's happening in their visit to help them kind of work out some of the anxiety and feel empowered to have these conversations. The systemic application is staff trainings on patient-centered language and nonverbal communication. And when I say staff training, anyone who talks to the patient should be involved in some type of training. There have been a number of times where the patient had a great interaction with their physician or practitioner, whoever is working with them, but they had a horrible experience with the front desk staff. And that experience can then taint the subsequent experiences that the patient has with the rooming tech, with the resident or whoever else is coming after that initial front desk staff person. So whoever talks to the patient should have some training about patient-centered language, nonverbal communication, disparities in communication. So I think that we are at around the 15-minute mark. So I will open things up for questions.
Thank you, Dr. Bell, for a really excellent and thought-provoking talk. I was really excited to get to hear what you had to share with us. We have several questions in the chat, and other people feel free to add questions as we go. So our first question is, has there been research to explore if there are different or better outcomes for Black prenatal patients being treated by Black OBGYN providers?
The research in obstetrics is very limited. We can kind of rely on research that we have in terms of racial concordance studies. In general, there are better outcomes when there is racial concordance than there are when there is a discordance. And so that translates into longer visits with more patient-centered communication, visits with more affect and patients reporting greater trust in the provider and greater satisfaction. So that is there. It's just limited in the area of obstetrics. One word of caution is that there aren't enough providers of color to go around. And so I think there is some data to show that 80% of the providers that Black patients will come into contact with will be white or non-Black. And so while racial concordance, there is some improved benefit, researchers are really thinking that, what is it about the racial concordance? And some are hypothesizing that it is about the trust that maybe initially is there, but there's something about the patient-centered communication that really is the icing on the cake. And so the patient-centered communication are things that are malleable, they can be taught. And so maybe that is where we focus efforts in teaching everyone how to do that, just because there isn't enough providers of color to go around.
Good point, thank you. We all have a responsibility to learn how to care for all of our patients. Let's see here, Dr. Bell, I have worked in a rural hospital as a member of the palliative care team at this hospital. Due to systemic racism in this hospital, I have seen Black patients and their family members who have experienced racism have a difficult time hearing the palliative care team when a patient has a terminal diagnosis. Very often, I have seen that these patients and families feel as though our team is not giving the same respect to them as we do to white patients in similar experiences. Unfortunately, I have seen this leading to patients and their families suffer when they make decisions to prolong their life, which leads to increased suffering for the patient and families. How would you recommend to work with individuals who are Black to show them that we are providing the same quality of care as we would to someone who is white regarding end-of-life care? Thank you for your assistance.
Absolutely. Thank you for all that you're doing to support the patients that you and their families that you come into contact with. Um, I think one, kind of going back to the slide before now, those elements of individuation, those elements of patient-centered communication, when there is a discrepancy in what you're hearing and what you're seeing, our default is to rely more so on what we're seeing. So making sure that your posture is open, that you're making eye contact, that you're leaning in. And I know that that sounds not effective, or that doesn't feel like this big bang for your buck. But again, when I talk about the communication coaching skills, these skills oftentimes have multiple outcomes or multiple benefits. And so those are just small elements that you can make sure are intentionally present in those visits. Again, asking about patients' experiences and in a way that they feel like you're trying to understand and trying to hear them, trying to see them. And also collecting some data anecdotally that maybe you can take back to someone in leadership to present to them to say, this is what patients are saying, this is what patients are experiencing, what can we do? I think it's very challenging to be in a position, and a lot of people are in a position like this, where they see disparities and they want to change, but there's leadership, there's a ceiling, there's not as much support to help them. So one, I would rely on some of the communication skills that we talked about in the visit with those patients, knowing that those things are great and good and can help move things forward, but potentially not enough without the leadership support to maybe make some changes, make some hard decisions. I hope that that answers a part of the question. If not, please pop on and help me clarify if I did not answer that.
I guess I would like to ask a little bit more about whether you think it's ever appropriate or in fact important to ask patients directly about their experiences with bias and racism in their care, and to bring that into the conversation, and what you think that might look like.
Yeah, I do think that it is important to see the patient as holistically as possible. And so there are many times where patients have shared feeling like they weren't listened to, or that their symptom was dismissed. And they're entrusting me with this information. And they just want to talk about it. They just want a space that feels safe to talk about it. And I think that it's important because especially if you don't look like the patient, to create a space where you can talk about these things, not that you're going to be getting together and then going and, doing some escalating that, but patients often just want a safe space to talk about it. And that can be so emotionally corrective to do that with someone that doesn't look like them. And so I would say it is important to offer the opportunity to do that. Just in general, how has your healthcare experience been in our setting? What are some of the challenges that you've run into in our setting? What are thoughts that you have that could make that better or different? Patients often have solutions. We often give patients solutions, but they often have solutions, and we can partner with them in those solutions if it leads to that. But I think it is important to ask those questions. And it helps you to, again, individuate, to help you to see the patient is, oh, wow, this patient is struggling with this, and they're also struggling with this. This is a barrier.
Thank you. All right, we have lots of great questions popping up here. So thanks so much for this fantastic talk and your important life-saving work. What would you recommend for a healthcare system without a coaching system infrastructure as a place to start?
Right, I would say to start with the the communication literature, to look at evidence-based communication strategies and skills and what's been shown to be effective, and to start implementing those, training staff, providers, front desk employees, whoever you can get to, training them in these evidence-based strategies to interact with patients. I do think that there is something it is an advantage to have an embedded communication coach, because that person is then there to work with the department. They can identify systemic issues as they arise. They can identify patient level issues. But as psychologists, we're kind of poised to do that. And so I would say, start with the literature, keep your eyes open, bringing this literature and findings forward to your institution, even just as a conversation starter. Like, many people don't know that there's a communication disparity with Black and white patients. And that in and of itself can be a move towards a more positive atmosphere and environment for patients. If people know that this exists, they can be more mindful and watchful of it, especially if they're equipped with the strategies to make a difference. I think I mentioned earlier that some of the trouble with the implicit bias trainings is that they increase awareness, but they don't give providers or folks concrete skills of how does that translate? How does my bias translate into actual communication behavior? Oh, I don't make eye contact. Oh, I'm always facing away from the patient. Oh, I'm always rushed. I can work on that. So I would start there with the literature and move those skills forward.
Excellent, thank you. I'm interested in Dr. Bell's thoughts on addressing the implicit bias in sickle cell disease, particularly in the ED setting.
Can you share, do we know who wrote that? Can they share a little bit more context for the question?
Dr. Lacomer, are you on the call still?
Yes, I am.
Okay, great.
So typically or frequently, patients with sickle cell disease are viewed as drug seeking when they come into the ED, and their treatment is very problematic as a result of that initial perception.
So I think that this is twofold. One, documentation, making sure that documentation in the chart is done so using person first language, having some type of discussion training around why that's important. Use of standardized patients could be particularly helpful in having providers or staff practice this skill in a much less threatening scenario than in vivo with patients, and to provide feedback around what was observed. I think that sometimes having an experience, having a face, a narrative with a condition is so helpful. If there are patients who may have been identified through patient relations or other means that can come to a staff meeting that feel comfortable sharing their experience, what it feels like when they walk through the room, that has been so impactful for providers to hear that message and to think about there's a whole person behind the label or series of labels that are in front of the patient oftentimes. So those would be a few of the recommendations I would make in that scenario. I think the biggest is with written communication, because it's so priming. You open a chart, you see a label, you see a word, and now you think that this is, all right, I gotta deal with this patient and deal with this, and it really impacts the visit. So I think the biggest part of that is the written communication about the patient.
Great, thank you.
Thank you. Are there specific checklists you use as a framework for increasing patient-centered care or physician communication during your observations?
Yes, we use an adapted form of the Calgary, which is an outline of the medical visit from beginning to end, with certain communication behaviors, verbal, nonverbal, that take place in each of those pockets of the medical interview. And so we go in, we observe, we use that checklist to provide feedback, but then there's also other things that we might see that isn't necessarily on that checklist. So for example, I mentioned maybe using endearments, which isn't originally on the Calgary, but using terms like honey, baby, sweetheart, my love, things like that, that are off-putting to patients that we see and provide feedback around as well. But there are plenty of checklists that can be adapted, the rotor, the 4 habits that can be adapted to use in an institution.
Is the checklist publicly available? Is that something that we could send around to people who are registered today?
Those those, yeah, you can, if you have access to the internet, you can find the 4 habits, you can find the Calgary, you can find all of those.
Great, thank you. So we can see how much incredible interest and excitement there's been in this important topic. So thank you so much, Dr. Bell. We weren't even able to get to all of the questions. I just want to read one last comment to you that I think probably reflects what many participants here are feeling. Thank you, Dr. Bell, for giving me actual actionable information. I found that to be a rare event in CE events I've been attending on racism and psychology. So helpful, an excellent presentation. So thank you very much. And I'm going to turn it to Barbara, who has a few final notes for us.
So thank you once again to everyone for attending the webinar today. Remember, if you'd like CE credit for attending this event, please respond promptly to the evaluation link, which will be sent by email shortly. If you joined by phone and wish to receive credit, please send an email to apadiv38@verizon.net to identify yourself. We'll leave the evaluation open until June 25th, 1 week. CE certificates will be sent by email within 5 to 10 business days after the evaluation period closes. And remember, you're invited, encouraged to submit an evaluation, even if you're not seeking credit. You may email us at apadiv38@verizon.net if you have any questions. And last but definitely not least, thank you so much, Dr. Bell, for this amazing webinar. And thank you to all of our participants today. We hope to have you back again soon.
And don't forget to sign up for the Women's Health Interest Group if you're not already a member. Thank you very much.